Today we're going to do a case study walkthrough of an ACL tear, one of the most common injuries that you can have, especially in various different types of sports because of the common mechanism of injury that is happening with an ACL tear. So we're going to be doing a full case study walkthrough following the Hobbs procedure as we do in the biokinetics profession. So we're going to start with just the basic details of the patient first. So our patient's name is Daniel, he's 29 years old. His occupation is an accountant, and then he plays volleyball on the weekends, and then his primary complaint will be his knee pain. So then we'll move into the case study as it is presented. So I'll read it to you. He is a 29-year-old volleyball player who injured his knee during a match last weekend. He jumped to block a spike, but he landed awkwardly, and on his right leg it was slightly rotated inwards upon impact. So that is the case study we have. So moving into our first component of our Hobbs procedure, we're going to move into history. So usually I like to do 5 questions, and the 5 most relevant and important questions that you can ask for these case studies. So the first question I always like to say is what happened and when it happened. The what happened gives you the mechanism of injury, and why that is so important is if you have any mechanism of injury, then you can always structure your assessment surrounding that mechanism. So in this case, if we have an ACL tear, which we are suspecting, then the mechanism would be anterior translation of the tibia, as well as rotation, which would cause that stretching of the ligament and eventual tearing. So the what happened we have in the case study as it presented, he landed awkwardly while his leg was rotated inwards. So what we can do in this case, instead of the normal what happened, is we can just dive a little deeper into that question, and we can ask how was his movement post-game. Was it limited? Did he feel any pain after the match? Did he go directly to the hospital or see any healthcare professional after the incident happened? Because we can immediately deduce from the case study that this is a traumatic injury and not an overuse injury, because it was an incident that occurred and it was not a gradual onset of pain. Then the when it happened will always give you an indication of severity. If it happened a year ago, then it means the pain was manageable and the patient could bear with the pain. But if the injury happened recently and they sought out help immediately, then we know it's a traumatic injury, and we know that the patient is on his way to recovery or has been dealing with surgery, and this is now post-surgery, or they want to take the conservative method where they don't want surgery so they came to you. So our first question would be the what and when, and then moving into our second question, I always like to say location and type of pain. So location is if you don't know what the diagnosis is yet and you are uncertain, asking your patient to specifically point out the section in which they feel pain. Because our body is segmented into different parts, we have our anterior, which is front, and posterior, which is back, your superior, which is top, and your inferior, which is bottom, then your lateral outside and your medial inside. Once you ask the patient, for example, if you ask them on the shoulder joint, where do they feel pain? If they were to point in this region, then you would know it's an anterior superior region, more on the medial aspect. So you can eliminate a lot of the structures within the shoulder joint, specifically medial deltoid, posterior deltoid, and certain of the ligaments and tendons and muscles involved. You can start to narrow down and see where your assessment is going. So for the case of an ACL, most commonly people present with posterior pain because of the attachment point and the insertion point of your ACL that spans from your femur to your tibia. They usually feel that ACL pain towards the back of the knee just because of the proximity of the ligament there. So when you ask them to point to the pain, they will point to the back of the knee. That doesn't necessarily mean it's a posterior injury. It just means because your tibia was translated anteriorly, now that pain will present in the posterior aspect. Now, when we speak about type of pain, again, we are eliminating certain factors in this case study, because we know that when we see a muscular type of pain, it will be a sharp localized pain. When we see a bone pain, it's going to be an aching and a deep pain. And when we see neurological pains, it will most likely be referred radiating pain with tingling, numbness, or paresthesia. So when we ask that question, we can also distinguish between structures such as bone, muscle, and nerves. So that's for our second question. And then our third question, you can ask them about previous injuries or previous treatment. So the previous injuries, if you were to deal with an overuse injury, people with tendinopathies tend to have reoccurring instances of this. So if they have patellar tendonitis, chances of them getting it again is very high and is dependent on their training schedule, but it can happen very often. So asking that previous injuries, especially if it was an overuse injury, it can give you indication if it's reoccurring or not. And then previous treatment, just to know what phase of rehabilitation you can start them in when you do your program. Then for question 4, we're moving to aggravating and relieving factors. Now I want this question to be more specified than just that plain question. You want to do an individualized program. Not every patient presents the same, so you want to ask them what movements in their daily life. If this patient is now an accountant and they play volleyball, do they have stairs at their work that they struggle with? Is their house a 2-story house or 1-story house? Do they struggle getting in and out of the car? Do they stop playing volleyball completely? So that you can tailor the program to their specific movements. Okay. And then question 5, I'm going to ask you in the comments down below, what question do you think would be relevant to ask this patient in a case like this? Okay, then we move on to our observation portion of the assessment. So for observation, we'll start with postural abnormalities. So what you would suspect to see in an ACL tear, most commonly is the patient will weight shift. So they don't want to put their weight on that injured knee. So what's going to happen is they shift their weight to the leg that is fine. Let's say they had their right leg injured, they will shift their weight to the left leg. Now, commonly they'll bend the knee that is injured so that that weight is not displaced on it. So we call that ipsilateral knee flexion. And commonly we'll have contralateral or opposite leg knee hyperextension or just plain extension for that compensation and weight. Now with that, your hips and your knees, because they are aligned, if your one knee is bent, then your hip will also drop. So we'll see a lateral pelvic tilt towards the side of the injury where the one goes down and the other one goes up. Along with this, you can see a possible ambulatory device, so using a crutch or something to help them walk, because again, they don't want to place weight on that affected leg. And then I want to ask you again, what other postural abnormalities would you suspect to see in a patient that has an ACL tear like this? If you put it down in the comments below, I'll be sure to check it out and then let you know if you are on the right track and if your comment was valuable to this case study, or if it's even something that I missed during this assessment. Okay, then if we move to volleyball specific, because this patient is a volleyball player, there are certain sports that can present with certain postural abnormalities. So the way volleyball players present, they usually have a quite broad stance, so their feet might be out. They tend to use their quadriceps and hip flexor muscles a lot, so suspected anterior pelvic tilt, pulling that pelvis forward, and along with that the lumbar lordosis, because they do tend to sit on their knees a lot, bending a lot forward, causing the rounding in that spine. Okay, then if we're going to do palpation next, we can do gait as well, so we'll start with gait first. So for me, gait is always just a prolonged posture because it's now a moving posture. So many of the abnormalities that you did see in your postural assessment, you would also see in gait, but just a bit more severe or a bit more upscaled. So in gait, you would expect them again to weight shift towards that unaffected leg, so you would see a reduced stride length on the injured leg and you would see an increased stride length on the opposite leg. If they are using a crutch, then you'll see a lot of weight shift onto that crutch. They will tend to keep that one knee flexed, which will cause that lateral pelvic tilt or a Trendelenburg gait as well. So then when we move to palpation, so I start my palpation with bony structures first. We have a skeleton for a reason. In that skeleton It's going to provide us with the points that we should know about where the muscles originate and where they insert. So we have a basic understanding, because every person is different, where their musculature will run through. So in the bony landmarks, we will start with the femur, because you start away from the injury and towards the injury. So you'll start with your greater trochanter, your ASIS, then you can move down towards that TFL ITB area into the lateral epicondyle of the femur, palpating the patella bone as well as the medial epicondyle of the femur, and then also the joint line. Then you more or less have a layout of what your land is. Then when you're moving into your muscular anatomy, you will want to do all 4 quadriceps. So your vastus lateralis, vastus medialis, vastus intermedius. You can't really palpate for that one because it is a deeper muscle. So you would rather palpate for rectus femoris, which is more of a superficial muscle. Then moving into your hamstrings, your semitendinosus, semimembranosus, and your biceps femoris. And as mentioned before, your tensor fascia lata and your ITB, or your iliotibial band. These are the most important structures found in the knee. If you would like to go lower down, then you can include gastrocnemius, because it is a 2-joint muscle and it spans across both ankle joint and knee joint, and it will play a significant role in the locomotion of that specific joint. And then when we move to ligaments, tendons, and muscles, you can always just palpate that popliteal fossa, where it is the posterior aspect of the knee and the most pain will be present, as well as some inflammation, swelling, and tenderness. And then in accordance with that, you would also like on the lateral and medial epicondyles, just feel for that LCL, MCL complex if there's any swelling or any accompanied injuries that happened in that region as well. Then your quadriceps tendon and your patella tendon, which you can palpate because they are superior and they are not deep within the tissue. Okay, then when we move into our flexibility, for palpation, there is one more group that you want to focus on. So with your vastus medialis, in accordance with them, you also want to look at your adductor muscles, specifically because when the knee collapses inwards, that causes a risk factor for another ACL tear. And the muscles that are responsible for keeping your knee in that outward position or keeping them from falling inwards. So your abductors, your hip abductors, will keep your knee out, and your VMO, vastus medialis, and your adductor magnus, longus, and brevis, and your gracilis muscle, those ones helps the knee from collapsing inwards to stabilize that knee joint. So palpating them for any atrophy or tightness would also be relevant. So then when we move to our flexibility, again, I do rank according to importance. So I will have my primary, my secondary, and then my accessory movements that I test for. In this case, because it is our knee joint and it's a hinge joint, there are only 2 movements that are present. So doing knee flexion and extension would be the 2 most prominent tests that you would do, especially because clearance for an ACL would be to reach your terminal knee extension first and then moving on from there. And then moving on to our accessories, doing something like a hip flexion with knee bend to assess your glute flexibility. And in that movement, you are also bending the knee almost to a hyperflex position. So that test would also be adequate to see range of motion and improvement of range of motion. And then the 5th one, just to test for some tightness and for that postural lateral pelvic tilt. To test glute medius, you can do hip internal rotation to see if that lateral pelvic tilt is caused as a result of tightness or over the compensating time that they have had that lateral pelvic tilt, if tightness has accumulated. Then in the comments, if you'd like to add a flexibility test that you see is necessary or you think is relevant to this case, then you can add one and I'll take a look at it. Moving into our manual muscle strength, usually your movements are more or less similar for flexibility and MMT with the exception of some movements. So again, it's primaries, your secondaries, and then moving into your accessory muscles. So our primary and secondary would be your quadriceps. It would be all 4, not just your vasti group, but including your rectus femoris as well, because it is a prominent muscle in that action. Then your hamstring group as well. These are our primary 2 movements. And then in our secondary, then we are going to do our hip flexors, so iliopsoas and rectus femoris as a group. You can test them without doing knee extension, and this is valuable because in your exercise program, doing hip flexion exercises will by addition add strength to your knee joint. Because you are training rectus femoris, which is a 2-joint muscle, you are indirectly helping the strength of that knee joint become more without doing movements that involve knee extension and knee flexion. So while you're doing isometrics for your knee flexion extension movements, you can still do isotonics for your hip flexion movements, and then indirectly strengthening that muscle that still adds to knee extension. And then our accessory muscles, like we spoke about in palpation, that adductor group to help the knee from falling in, and that glute medius so that you can correct that lateral pelvic tilt. Then before we move on to our special tests, if you had a different diagnosis for this patient or any other conditions that you think it would be, then you can put them in the comments and tell me why you think it might have been a different condition and give me a good substantiation, and then we can walk through that. But in this case, if we review what we've seen so far, the signs and symptoms were reduced range of motion. There was pain in the posterior aspect of the knee. It was a traumatic injury, and then it was a localized pain in that area. Then the movements that were restricted was knee flexion and knee extension, and then the postural adjustments that came with is that pain compensation or weight shift. And then the last thing is the pain level was quite high. So in reviewing all of those facets, you would suspect something like a traumatic ligament tear, even a bone fracture, but because of the symptoms that are presented and the area they presented in, we have deduced that it's an ACL tear. So in our special test, the special test that we would do is your anterior draw, your Lachman test, and then if you want to do any accessory, so you do your anterior draw and it's positive, and then you can do a Lachman test to confirm that positive for the anterior draw, and then doing any accessory functional tests, you can do something like a Trendelenburg test again to test for that lateral pelvic tilt. The Trendelenburg is a great test because it not only assesses one joint but does hip joint, knee joint, and ankle joint. So to see where that stability issue is stemming from, is it the knee or the ankle or the hip that's the problem? If one of them are the problem or all three of them are a problem, then you can deal with the root cause for that thing. Okay. Then when we look at just the overall of this case that we presented with, the ACL, the main question I usually ask people when treating a patient or when seeing a case like this is the two questions that I ask is explain to me what the condition is, and then the second one is how do we fix it. So explaining an ACL tear, like we said before, is an anterior translation of the tibia in relation to the femur. So moving into how we fix it, we have to make sure that that ACL is not vulnerable in any state of range of motion. Usually because of that valgus varus complex or the knee falling inwards, it is in a compromised position, or when the knee is excessively straight or excessively bent and it's rotated, then again it's in that vulnerable position. So training those adductors to avoid any knee valgus occurring would help with offsetting that possible risk of re-injury, as well as strengthening the quadriceps and hamstrings in full range of motion according to normative values is going to help the muscles take most of the strain throughout the entire movement. Okay, so that was a quick review on an ACL case study, and I would appreciate if you would like and subscribe, and then add your thoughts in the comments, and then I will continue doing these as we go along. So if you have any requests, just put them in the comments, and then we'll take it from there.